Reproductive pathology is a fairly large section and there's a lot of high-yield material here. I do recommend having a strong understanding of the anatomy and physiology before starting this chapter. Also, brush up on your endocrine since I will be integrating a lot of that also. Now to tame this beast. So let's start with sex chromosome disorders. Quick review. What is the normal karyotype in humans? That's right, it's 46XX in women and 46XY in men. Now, Klinefelter syndrome occurs in males who have 47XXY. So, how do you get that extra X chromosome? It usually occurs when paired X chromosomes don't separate during oogenesis, or when the X and Y chromosomes don't separate during spermatogenesis. In other words, they're examples of non-disjunction. As in normal females, one of the X chromosomes will be inactivated as a bar body. As a side point, on the USMLE, bar body may be often referred to as extra electron dense aggregate in the nucleus of the cell. Bear in mind that a bar body is heterochromatic, meaning that it's not transcribed and is therefore compact and electron dense. Euchromatin, in contrast, which is transcriptionally active, would not be electron dense. In terms of presentation, Klinefelter patients are tall, long-limbed, developmentally delayed, feminine, infertile males, and they have gynecomastia. There's just a few buzzwords that you should really be looking out for this condition. In the question stem, you might actually confuse them for someone with Marfan syndrome at first glance, but the secondary sexual characteristics really give it away. So what causes Marfan's again? Correct, it's a defect in the fibrillin gene. You can see some of the feminine features here on the image, as you can see some gynecomastia, the hips over here with the female phenotype. So Klinefelter patients are classically described as having a unicoid body shape. So this is a word you want to also be looking for, as they have both male and female sexual characteristics. One of the major sequelae is that they have testicular atrophy, which leads to dysgenesis or defective development of seminiferous tubules. Their deficient Sertoli cells don't make inhibin, so you get no negative feedback on FSH production. This means that you end up with high FSH, which is one of the major tests you can do for the disease other than direct karyotyping. The abnormal Leydig cells will also produce less testosterone, leading to increased LH, along with the increased FSH. Since the aromatase in the Leydig cells is intact, that trace testosterone is converted to estrogen, specifically estradiol. It's the increased estrogen to testosterone ratio that leads to the gynecomastia. It also puts these patients at a much higher risk for breast cancer. So the way you might see this question is something like, if you have a patient with bilateral breast development, tall stature, and small firm testes, what abnormalities do you expect on lab evaluation? The answers would be high FSH as well as high estrogen to testosterone ratio. Now, let's discuss the other major sex chromosome disorder, which is Turner syndrome, a disorder where females have the genotype 45XO. This is another example of non-disjunction where the sperm or egg is missing the X chromosome prior to fertilization. These females have no bar body because they have only one X chromosome and no extra copy to inactivate. In terms of disease phenotype, patients with Turner syndrome are short females who have a shield chest and webbed neck secondary to poor lymphatic drainage. These patients are often born with a neck mass. Do you remember what that neck mass is called? That's right, it's called a cystic hygroma. And it's just a fluid-filled mass. It does not contain any cells. Here's another picture of Turner syndrome, and you can see the webbed neck over here. Because of the XO genotype, patients have only one copy of the S-HOX gene, which we had talked about in embryology, instead of two. This gene is responsible for long bone growth, so that's why they're so short. Another clue is if the patient has preductal coarctation of the aorta. Most coarctations occur downstream with respect to the ductus arteriosus and are therefore postductal, but Turner syndrome patients get them upstream. Remember then, from cardiology, what you would see on physical exam. Do you see cyanosis? Yes, you would see cyanosis because there is low pressure distal to the coarctation, which allows shunting of deoxygenated blood through the ductus arteriosus. You would not observe this on a postductal coarctation because the pressure differential doesn't develop until after the ductus arteriosus inserts. Some other things to keep in mind are that these patients have non-functional, what we call streak ovaries, and therefore decrease estrogen levels and increase LH and FSH, which results in primary amenorrhea. Turner syndrome is actually the most common cause of primary amenorrhea. So what's the difference between primary and secondary amenorrhea? Primary means that they have never had a period, whereas secondary means they have had normal periods in the past, now those have stopped. If you get a question asking about primary amenorrhea, you absolutely have to think about Turner syndrome. Differential diagnoses might include Mullerian agenesis or anatomical abnormalities like imperforate hymen or vaginal septum. So, true hermaphrodites are rare and have both ovaries and testicular tissues, otherwise known as ovotestes. As you can see on the right, there are some primordial follicles over here, while over here on the left you can see some immature seminiferous tubules. Because of this, they have ambiguous external genitalia. So very tall, severe acne, antisocial, and 47XYY genotype. These are seen in double Y males. Unlike males with Klinefelters, they have normal fertility. Some studies link this genetic abnormality with behavioral problems like increased aggressiveness and a higher incidence of antisocial, like autism spectrum disorders. As you can see in this image, these males have two Y chromosomes. Now, this is a very high-yield table in first aid that will help you separate the major sex hormone disorders. I've recreated the table here. Instead of memorizing this, understanding these trends will help you even more. One key here is to remember from our discussion of the HPG axis in the last section that LH stimulates testosterone release. The second key to helping understand these concepts is to think back to our discussion from endocrinology about feedback loops. If you have a defect in a signaling pathway, hormones upstream of that defect will be upregulated because they're not getting normal feedback inhibition. On the other hand, if you have abnormally high levels of a hormone, it will lead to more than usual feedback inhibition, so the upstream hormones will be suppressed. Finally, in addition to levels of the hormone itself, you also need to think about responsiveness to the hormones. After all, a hormone is really just a messenger, and it needs a functional receptor for the message to be transmitted. Now, a patient with defective androgen receptor, for example, would be unresponsive to androgen. Thus, through lack of inhibition, LH and testosterone would be upregulated, and yet they would have no effect. A primary example of this is androgen insensitivity syndrome, and we'll talk about that in a couple of minutes. Another example would be a patient with testosterone-secreting tumor or a patient who is using exogenous testosterone, so they will have high testosterone that will decrease the LH by negative feedback. Therefore, these patients will have high testosterone but low LH. Next, we have primary hypogonadism, which is a condition where the gonads do not function properly and do not respond to LH. Thus, LH will be high since the body is trying to stimulate the end organ's testosterone, but testosterone will be low since no matter how strong the message is, the effector organ just can't comply with it. In hypogonadotropic hypogonadism, the defect is typically with the hypothalamus or the anterior pituitary, and not the gonad. So what would you expect to see with LH and testosterone levels? You basically see low LH levels leading to low testosterone levels, since in effect the gonads aren't receiving any message from the hypothalamus. An example is Kalman syndrome, which we will discuss in a bit. The next topic we'll talk about is pseudohermaphroditism. Do you know where the word hermaphrodite comes from? In Greek mythology, Hermaphrodites was the child of Hermes and Aphrodite, and this child had features of both males and females. Nowadays, though, it's useful to know that the preferred term in most settings is intersex, but some physicians still use the term pseudohermaphrodite. Basically, this condition is the disagreement between phenotype, i.e. the external genitalia, and the gonadal sex. So we have phenotype different than genotype. So female pseudohermaphrodites have the genotype XX. They have ovaries, but their external genitalia are ambiguous or more male-like. One way this happens is that during their fetal development, they may have had some exposure to testosterone, either exogenously or endogenously from congenital adrenal hyperplasia. Quick endo review. Do you remember what enzyme deficiency is the most common cause of congenital adrenal hyperplasia? That's right, it's 24-alpha hydroxylase deficiency. Now for male pseudohermaphrodites, they have the genotype XY. They have testes, but the external genitalia are female or ambiguous. Again, the big example is androgen insensitivity syndrome or testicular feminization. The way to remember male versus female pseudohermaphroditism is that if the patient's actual genotype precedes the pseudohermaphrodite, like female or male, so a male pseudohermaphrodite is actually male, but will look female, alright? So here's a flash quiz. If the androgen receptor is dysfunctional, what would be the LH and testosterone levels? They would both increase.